Kia ora everyone, good morning. I feel as though I have met many of you, but certainly not all. By way of introduction, my name is Peter Kennelly. For the last 7 years I've worked at the Ministry of Health on alcohol and other drug treatment issues. I'd just like to take this opportunity to introduce you to my colleague Shane Collett, who's the Principal Advisor at the Ministry of Health as well. In setting the context for today, I hope to begin by answering these questions for you. So what is the context for today? Why youth exemplar services? Why has the Ministry used this term exemplar? What are they expected to do? And will they be evaluated? As part of the context today, I want to go back 5 years to a paper that Grant Christie wrote, which really I think set the scene for how youth addiction treatment services could be in this country. And I'm very pleased that Grant, in the very next presentation, will be able to give us an update on his thinking from this very important paper. Also in 2009, NCAT put out a position statement. I just wonder how many of you remember this. I think it was the second or third one that you put out. So congratulations of being innovative around that. This was published around the time of Fresh Start and some of the debate that was happening at that stage around what are effective services for youth. I just want to quote one part of it. NCAT supports evidence-based policy initiatives that have proven effective in reducing alcohol-related harm among young people. These policies must exist side by side with a cohesive and well-resourced network of effective local treatment initiatives. If I was to describe exemplar services, those would be very much the words that I would use. A cohesive and well-resourced network of effective local treatment initiatives. So just keep that in mind today as we go through the discussions. It's around how do we have effective networks. Also, the next big significant issue was Sir Peter Gluckman's report on youth in transition, and that really highlighted a number of issues for youth, and the response to that was the Prime Minister's own Youth Mental Health and Addiction Programme. That consists of 24, 25 plus initiatives, but there are two that are particularly relevant to the discussions today. The first one is how do we improve access for youth to addiction treatment services? And secondly, how do we improve discharge planning from specialist services back to primary care? We've adopted the term transition planning, and it's around how do specialist and primary care services start working together from the time a person first makes contact with the specialist service to planning what will happen post that care. The drivers of crime was also significant because it includes a focus on improving access to youth, alcohol and drug treatment services, and included $2 million of funding from alcohol excise tax to make that happen. We'd also just like to mention the work that was done by the Mental Health Commission around Blueprint 2 and the follow-up work done by the Ministry and others in rising to the challenge. And this really highlighted that there are inconsistent ways that services, not only for youth but for adults, are also delivered around the country, and raised this issue around how do we work, make better use of the resources that we have got, how do we bridge that gap between specialist and primary care, and how do we address youth issues in particular. There are various other initiatives as well that I can mention: Youth Forensic Service, the Children's Action Plan, the Youth Crime Action Plan. There probably are others that I haven't mentioned. But I would make the important distinction that while many of these have raised the issue of treatment services for youth, it was really Grant's paper that addressed how we could actually make that difference. And I think that's quite an important distinction. The other important issue for today, while we're all here, is actually having youth-focused services that are actually able to deal with the issues that youth are facing is absolutely critical. It may seem obvious, but I think we need to remind ourselves just why this is so important. Certainly youth are going to be reluctant to engage with health services, especially if they're labelled addiction treatment or mental health. So we need to be thinking around How do we present services to actually make them youth accessible, youth friendly? What we're seeking with the enhanced services is that they need to be more responsive to the issues of youth. It's around reorienting services to make them more available for youth. They need to be flexible and highly mobile, and they need to be multidisciplinary, evidence-based, coordinated care, and all those other things that we want. Why youth exemplar services? As I've said, when the work was done around Rising to the Challenge 2 and those sort of work, we really understood that services had developed without any particular pattern or any particular strategy. So we've got inconsistent services. We want to move away from a situation where the service you get depends on what part of the country you're in, to having a more consistent approach. That's not to say that there needs to be only one model. Obviously people can tailor things to their own local needs, but we need to have more consistent services. Youth AOD services are an important contributor to health and well-being for young people. Again, that seems obvious, but we need to be really emphasising that. And this initiative started off looking at two new exemplar services. I'll talk a little bit more that we've been actually able to extend that a bit further, so I'm very pleased about that. So why has the ministry used this terminology exemplar? We didn't want to use the word pilot because it's not a temporary thing. We didn't want to use demonstration site, although it does include aspects of that. So we were trying to come up to somehow mark that this is different from what we're doing, this is different from what we've done before. Exemplar is not meant to indicate some sort of elitism. I'll just make that quite clear. We aren't saying these are necessarily the best services anywhere, but they've got those aspects that we're really seeking in all services. It does imply, and services will be required to be available to share their knowledge and processes with others. So in that sense, yes, they are demonstration sites, but we want that knowledge transfer. That innovation needs to be spread across the country and not be kept in silos. We also need to acknowledge that many services will already be demonstrating some of the features that we'll be talking about today. And there may be already exemplar services that are out there that are covering lots of this, but what we want to do, again, I come back to this point, we need to have greater consistency nationwide. So, if not exemplar, perhaps enhanced or perhaps integrated with other youth services, take your pick, but we're trying to give you the impression that what we're talking about is something different from what we're doing, something different from what we have done in the past. What are exemplar services expected to do? The first thing I'd say what they're expected to do is actually to provide treatment. There's been a lot of media issues raised the last few weeks around people trying to access services in relation to their psychoactive substance use. And what we're hearing is that people can't get into treatment. And I think we'd like to have some discussion in small groups around that perception today. Is that so? What is actually happening out there? Not only for psychoactives, but for youth in general as well. We need you to be able to build a critical mass of clinicians, and that's really important. What are the range of skills? What are the range of connections that you need to be making to better be able to respond to youth with coexisting mental health and addiction issues? We need services to be able to work with the young people's family as relevant. And we shouldn't underestimate the amount of time that has to be put into actually establishing those relationships, particularly with family. We need to improve the resilience and have relapse prevention policies, and that's where transition planning will come into being very important. And also, there's all those other agencies, not only in the health sector, but those other agencies that are involved in young people's lives. We need to be able to make good connections with them as well, whether it's school boards of trustees, whether it's SIFs, whether it's justice sector agencies, all that. So quite a lot of connections to be doing there as well. And how does that actually impact on your face-to-face time with clients? If we're expecting you to be able to work with the local SIFs people, to work with probation, to work with school teachers, that reduces the amount of time you actually have available for face-to-face with the client. How do we balance that? Is there an optimal balance that we need to be addressing? I'm not going to go through all these design features. This is just a little pre-sample of the discussion that will come next when we hear from the frontline services themselves. But there's a whole list. CEP capable is pretty important, but then so are all the others as well. So to save time, I'll quickly move on. I just want to cover how were these exemplar services selected. The Ministry ran a registration of interest process. 6 proposals were shortlisted, and we asked those 6 services to go away and prepare a request for proposals. So quite a lot of work was done getting to a stage where the Ministry had something to consider. One of the important issues was to make sure that the people who were preparing the submissions had the support of the local DHB funders and planners. Funders and planners are critical in implementing these services. A panel selected 2 of the proposals to get the majority of the funding. We were able to support 2 others to get some funding to increase their capacity, and all 6 proposals received some funding towards change management, project management skills. So we think we did quite well with the funding that was available. Where are the sites that have been selected? Well, I'm very pleased to say in Northland, and good to see the Northland contingent here down the back, Jenny and Johnny. In Southern, good to see you, Deb, and thank you for bringing your team up from the Deep South. Wanganui, Bay of Plenty, Waikato, and the Wellington region. All quite different issues that you're faced with. Complex, complicated, all the rest of it. So I think we should have a really good discussion around identifying the challenges and the change processes. The new services will be evaluated. It will start with a formative evaluation of the Northern and Southland DHB sites. The formative evaluation will, I'll talk about that a bit more, but it will be about those particular services. It's not going to compare and contrast them with any other service. It is what was the situation prior to implementation, what's the situation since implementation. We do want to do a process evaluation later on for all 6 services, but as yet our thinking is still evolving on how we will do that, and we'll need to involve all the parties in how that might work as well. And we want to measure outcomes and any other achievements across all 6 sites at some stage as well. For the formative evaluation, we need to understand, have the 2 new services been implemented as we thought they would be? Are they delivering what we thought they should deliver? How can they be improved? And also to provide the Ministry with a basis for future investment reconfiguration decisions.